Well, good morning. It's a pleasure to be here. I was just telling some of my colleagues that it's so exciting to see where we're going with our efforts to serve and protect substance-exposed infants. This is a very important time in Colorado. So I've been, before I get started though, I not to put my community partners on the spot, but if you're from Larimer County and part of the collaborative effort in doing safe care plans in our community, would you please raise your hand so folks can see who you are? This effort would not have been as successful as it has been to date if it were not for the working relationships that we have with so many that are committed to serving the needs of these children. So I've been asked to come and speak with you today about our collaborative effort in implementing safe care plans today. There really does need to be a collaborative approach among medical and health providers and substance use treatment providers along with mental health. These families oftentimes, their needs are multifaceted, and our best approach is to collaborate our efforts around serving them. And we know that coordinated services and early intervention are critical in preparing families for optimal bonding and the health and the well-being of the infants that they have. So this is really, this effort is really about protecting our most vulnerable. Many years ago, I guess I want to say that it's been a privilege to be part of this effort today and speaking along with Dr. Catherine Wells and Jade Woodard. Both these two ladies are champions in our efforts in serving drug-endangered children in our state. And I've learned everything that I know about drug-endangered children from these ladies. We're very fortunate to have them be our champions in Colorado. So I do want to talk a little bit, give you a little bit of historical perspective about the collaboration in Larimer County. When I was asked to do the speaking engagement today, I decided to, in preparing my talking points, I decided to go back into my archives of minutes from our meetings and when we first started this collaborative effort. And it actually dates back to 2005. And I was like, wow, 2005, we've really been working at this for a long time. And since then, I think we've really, through our partnership, have evolved and working on a number of things that are important in this practice. Around that time, we were asked by Poudre Valley Hospital if we would be part of a substance abuse advisory panel. Because around that time there was some concern that they were starting to see an increased number of women presenting to the hospitals, delivering babies where there was a concern for substance exposure. And there was a lot of question and confusion around when they would identify a substance-exposed infant and a mother who may have been using during pregnancy, the need to report to Child Protective Services. And there was a lot of confusion about, well, what happens when we make a report? And is this the best approach to do with families that are facing these kinds of circumstances? And there was a lot of worry around the impact that would have on the family when a referral was made, because they really didn't know how we as a child welfare agency was responding. Along that same time, there was this increasing awareness around the hazards associated with the use, abuse, distribution, and manufacturing of methamphetamine. You know, there was a lot of worry in the community and multiple sectors of our community about how we were responding to this social problem. There was also more and more awareness around that time about the drug-endangered child and what does that mean, and how are communities really set up to respond to protect these children. And the subpopulation within the things that we were thinking about and worried about were substance-exposed infants, because there were instances where the hospital would be providing care to a mother who had just delivered a baby and had admitted to methamphetamine use during pregnancy, and the baby was suffering with some kinds of withdrawal symptoms. So the hospital, in their proactive approach, decided to put together this substance abuse advisory panel. And it was a multidisciplinary team. It was not only child welfare and people within the hospital setting, but it was also other subject matter experts within our community who had an invested interest in really serving this population and doing a good job about doing it. So that the other parties who came to the table and who had an invested interest were people in the substance abuse and treatment field, mental health, the health practitioners, law enforcement was at the table, and of course I represented the department on behalf of child welfare. And it was through this effort that we began really looking at our response to these families. The hospital was very curious, and we're having a lot of discussions about their screening procedures. There was, through this process, they were able to develop a maternal and infant screener, which is being used today, and I'll tell you a little bit more about that in the presentation. We worked on and talked a lot about procedures around mandated reporting. When do they report to Child Protective Services, and what can they expect to happen when they make a report? And what is the support and the services that they could expect families to get when they make that report? Because there was a lot of worry about how families were being treated when this particular issue was identified. There was a lot of discussion about what can we do to really get the family off to the best start possible, with a focus on well baby care. You know, we saw varied responses with infants that were being exposed. Some seemed to be pretty resilient and coming through it and not having any problems at all, and then some were like NAS and going through withdrawal and having a lot of difficulty. The other thing was, along with the substance exposure, these families were experiencing other psychosocial stressors or risk factors that would put these infants at risk for further abuse and neglect. So it made sense that in our response to serving these families, that we were doing everything that we could do to plan for the infant's safety and their well-being, but also to put things in place to mitigate other risk factors that may impede a caregiver's ability to successfully care for the infant. So we talked a lot about mitigating risk through safety and support planning, and then we just decided that the conversation with the family really needed to start in the hospital. It needed to start before the baby was discharged, and that if we could do everything that we could do to coordinate care prior to discharge, then we were really getting these families off to the best start possible. So all of this has been kind of evolving since 2006, and then when they rolled out safe care plans in 2017, because of our collaboration and the success we were having with some of our practices in this area, we were asked to pilot safe care plans. I think that our earlier efforts really set the stage for us being able to do this. So why do safe care plans? I think we're all familiar with the associated risks that come with substance exposure. You know, there's always a risk for attachment disorders. These babies have neurodevelopment and problems. They can have a number of behavioral issues as they're growing older. A whole host of medical issues can come into play. And there may be other associated risks that put them at risk for further future abuse and neglect. I think safe care plans conceptually make a lot of sense because they're really set up to focus on infant care, but more importantly, they're set up to strengthen caregiver capacity. And there's an evolution that's happening in child welfare in terms of our practice. And of course, we have that primary mandate to do everything within our means to keep children safe. But equally important to that is, what are we doing in our practice to strengthen families, to help them be successful in the care of their kids, and then consequently for preventing any future harm to children. So we know that substance-exposed infants can present a number of challenges for caregivers to care for them. And it's even more complicated, I think, if you have parents that are inexperienced, they're lacking resources, they're not coping well with their own lives. And this places children, of course, at greater risk for child abuse and neglect. So safe care planning, in my opinion, is a mechanism for engaging parents in a way that helps them be successful in caring for their baby and mitigating other risk factors that may come into play in the care of that child. Ultimately, if these plans are done well, we're going to see improvements. In child welfare, we're accountable to a number of child welfare outcomes, and they're all centered around keeping kids safe and them getting well and remaining well. So it all just kind of connects and goes together very well. So in our early work with the hospitals, it was important that once we identified a substance-exposed infant, that we could work collaboratively and in a coordinated response that would help parents get off to the best start possible with their baby. Around this time, in Larimer County and across the state of Colorado, we were rolling out a change in our practice model called differential response. It's one of the best things that's ever happened to Colorado, in my opinion, because it's given us an alternative way to respond to abused and neglected children, or to children who are at risk of abuse and neglect. And it gives us an alternative way to engage families in a way of improving circumstances in their life so kids are safe and well. And it removes the labeling and the judgment, the stigmatizing and the judgment that oftentimes comes with being involved with Child Protective Services. So the timing, it worked out really, really well, because with safe care plans, you have a similar idea or mission in mind, and it complements or parallels what we're hoping to accomplish in differential response model of practice in child welfare. With this population in particular, I think it's really important that we approach our work in a non-judgmental way. And the extent to which we do that is really going to set the stage for how we're able to get families off to the best start possible in their care of their infant. So as we stated here, we incorporated the goals of safe care planning into the approach with the family. We wanted to send the message to the family that we're all in this together. You're not alone. Oftentimes a risk factor in working with these families is the isolation that they feel. And kids are at greater risk when they're isolated and not getting the support and the help that they need. Through carrying out the goals of safe care planning, we are now in a better position to really work with caregivers in increasing their confidence and their ability to care for their babies. And it's through the education and the support and the resource provision that's offered that allows us to be successful in doing this. We also know it would be, for some families, it's necessary to add these additional layers of protection for the child, and we do that through safety and support planning for infants so that they're safe. In some situations, out-of-home placement of the infant is necessary. Because if the mother or the parents are struggling with a substance abuse problem and they're not able to manage that in a way that would ensure the safety of their infant, we may need to intervene in a different way. So if that's decided, what's really important, particularly for these infants, is that before the baby leaves the hospital, that we're able to engage other caregivers in their practice of caring for the infant, so the infant is safe and well. So as you can see here, it takes a team to carry out safe care plans. In the hospital setting, I'm so amazed just with the scope of services that are provided to serve the infant and to work with the caregivers providing care for the infant. There's nurse navigators, OB/GYN parentology, neonatologists, pharmacists, lactation specialists. I mean, there's just a whole host of things that are happening in the hospital setting. And then when we start to do discharge planning, we're preparing them for all of the community support that's available and accessible to them to help them be successful in the care of their infant. And it takes a lot of planning. It's not something that just happens overnight. And then there's a whole host of developmental services that have to be in place, because the care it begins in the hospital, but it doesn't end in the hospital. It's got to continue. And we rely on our community partners to help us sustain the good work that's actually started in the hospital. So earlier I mentioned to you in our efforts the hospital developed a maternal newborn and risk screener tool. So this was developed and it was designed as a screening tool for women who were admitted to the hospital. It asks a series of standard questions to identify any associated risks that they may need to plan for in patient care in the hospital. It also the questions are set up in such a way to look for other risk factors that might involve substance use by the mother, any psychosocial or risk factors that are important to know and to plan for in both the care of the baby while in the hospital or post-discharge, and also NAS indicators. Responses to the questions by the mother may trigger the need for infant screening. Earlier on in our efforts to do screening of infants, we were using the MEC-stat, testing the meconium, and then we moved more in the last, I think, 4 or 5 years to a cord-stat screening test. Another really valuable component of our model is nurse navigators. So once an infant with special needs is identified in the hospital, a nurse navigator is assigned, and they are responsible for coordinating the care. Currently we have 2 navigators. They assigned to both hospitals, and they cover on average 72 hours per week. They can also work with pregnant women, so referrals can be made for women who are maybe using substances during pregnancy. The nurse, when working with the family, will do a special consult. In that consult, she's asking a series of standard questions that are in guidelines with the safe care plans. The hospital is currently working on a consultation template. And there's a hope of theirs that this template can be put into the EPIC system. For those of you who are in child welfare, EPIC is their medical record, right? It'd be comparable to our trails. It's the way they keep track of the services that they're providing. It also comes along with a discharge checklist, and in the resource materials that were on the side tables, the examples of that work are provided to you in the folder. If you have an interest in learning more about that, if you want to email me at amead@larimer.org, I'm happy to connect you with our nurse navigators if you want to learn more about that program. So another component of the care that's offered is looking at non-pharmacologic treatment strategies. It's worth repeating here that these babies need their mamas, and they also need their mamas to know what they need. So there's a concentrated effort on the part of our hospital to use a relationship-based approach with mothers and fathers and other caregivers that may be involved in the care of the infant. And it's really important in their approach to be modeling the care that is necessary for the infant. And one of the things I've really appreciated about our collaboration and the work that's being done in the hospital is them offering this to secondary caregivers as well. So, earlier I mentioned sometimes out-of-home placement might be necessary for the safety of the infant. And when that happens, they be placed in a kinship arrangement or in foster care. So the hospital opening their doors and being so welcoming of other care providers is really helpful, because they can come into the hospital setting and be part of the care, practice the care of the infant, so they're feeling more confident when they leave and are responsible for the care of the infant. The goal really in working with the family is, or with all of the caregivers that are involved, is to develop a team of caregivers that feel confident in their ability to care for the infants. So with NAS, this was mentioned in earlier presentations. Some of our babies are experiencing symptoms that are consistent with NAS. And this slide is just going over a number of the strategies that might be used in the hospital setting to address the special needs of these babies. The education and support of other caregivers and increasing their understanding about the needs of these babies is really, really important. Because as I mentioned, we want to get the families off to the best start possible. So I mentioned earlier that sometimes babies will be put into out-of-home care, and if they are, we need other caregivers coming into the hospital setting. We know that babies will benefit greatly from caregivers who are informed and prepared and feel supported in their efforts to provide adequate care. When caregivers have the opportunity to come in and be educated and supported and practice the care activities of the infant, they're obviously going to feel more confident in their ability to provide care. It's equally important that if we have substitute caregivers, that they're also involved in the discharge planning process with the family. It's really important to us. We recognize that if a removal is determined necessary, that can have an adverse impact on the family and on the baby. And so to the extent possible, we really want to control for the impact and to have some compassion for the birth family when this decision is made. So we advocate that secondary caregivers work closely with birth parents, and that in the hospital setting, we start to have discussions and planning around parenting time for mothers and fathers. It's also really important to set up plans that allow for as frequent contact as possible, because we don't want to disrupt attachment and bonding, and that's a consequence that comes with removing infants from their birth mothers and fathers. So Poudre Valley Hospital and Medical Center of the Rockies, they are currently working with a model of eat, sleep, and console. Essentially what this means is that the infant has to have the ability to eat, sleep, and console with the help of parents or caregivers. Caregivers are going to receive the education and support that they need to ensure the baby can do that. This is there's a lot of discussion and planning and discharge around the eat, sleep, and console. And it's important that we, in our discharge planning for the baby with the family, that we are starting to connect them with vital supports in the community and talk about the importance of medical care follow-up, because this is essential in the long-term care of the baby. So there has been some discussion mentioned earlier today about the importance of how we manage NAS, and these are the standards of care for any infant that's showing signs or at risk of withdrawal. And I really appreciate these standards, because it just gets to the quality of care that's so important for the infant, and setting up the family in a way that they can be successful in the care. So it's interesting. This past year we did a training with our child protection staff. We brought the hospital in, and they were training our caseworkers. And actually our caseworkers were kind of training our hospital providers to our practice as well. It was very, very interesting. But the part of the training that really set well with our staff is the eat, sleep, and console. That just made a lot of sense to them. And the more they understood about that practice, I think it helps them in their efforts in engaging families as well. One of the things that was really actually very exciting about that training, I have to share, is when we get a referral that comes into the department on one of these infants, the referral goes to what we call a RED team. And a RED team stands for Review and Evaluate and Direct. And it takes all the information that we have in the referral, and we look at a balanced kind of assessment of both what are the things we're worried about and what are the strengths that are evident in working with families. And then they use the organization and analysis of that information to help inform the decisions, what they're going to do in their work with the family. And so what was really impressive is we actually had some of our hospital personnel come in, and they facilitated the use of the framework and looking at the referrals. And they did a great job. I'm like, I could hire them tomorrow. This works really, really well. So I have to commend the hospital's efforts around the development of educational resources. This has been invaluable to our parents and caregivers. And there's examples of some of the work that they've done in the packet of materials that were provided to you. But equally important to that is these have been invaluable educational resources for our caseworkers and child welfare. So many practitioners coming into the practice are right out of college. They haven't started their families yet. They may not have a lot of life experience with caring for babies, let alone substance-exposed infants. So this type of, this response and approach and the resources developed have really helped in educating us in what we need to know about the practice. So I wanted to just briefly talk about the discharge planning. This is a critical component of the model, and it starts at the point of admission. There's a lot of intricate details that go into the planning process for getting babies ready to go home, and it takes time to line everything up. The goals of the discharge planning really are focusing on the baby being well and safe, and also connecting the parents to those vital resources they're going to need support from. So the mechanism and how we do this is, it's called care conferences. And so if Child Protective Services is involved, we will have a caseworker from our department whose primary job is just to facilitate family meetings. So they're conducted at the hospital, and the reason why we conduct them at the hospital is we want the medical personnel who have been directly involved in the infant care to be part of that care conference. It's an opportunity to educate the parents or caregivers directly in the meeting. It's the opportunity to lend that support. It really helps with effective transition planning. It's also really good for the hospital personnel, because what I've heard over the years is many stories from them about the worry they have. They see these babies in their most vulnerable condition. And if they're suffering with withdrawal, how many of you have seen a baby going through withdrawal? It's traumatizing. It's so hard to see. And I'm so impressed by the medical care that these babies receive in our hospitals. They put their heart and soul into the care of these infants. And they need to know that when they leave the hospital, they're going to be okay, and that their care is going to be entrusted in the family and the support of the community. So that's the beauty of these care conferences in the hospital, is it brings everybody together, and everybody gets to discuss what the baby needs and what the family needs to be successful in providing care, and everybody gets to play a part in that. So it's a great process. Now, some care conferences can be facilitated by the hospital themselves, and if Child Protective Services isn't involved. So, so we talked a lot about what's happened in the hospital and how we prepare for leaving the hospital, and then there's this whole transition time of babies going to their homes and into their communities in which they live. So we know that there's going to need to be a whole host of support put in place post the discharge. And so this is just a continuum of services that we're looking for in the community to help the parent be successful in the care of the infant. Early intervention was mentioned in an earlier presentation. This is an invaluable resource to us. I think there are some challenges, though, around the eligibility criteria, and maybe not all women are eligible for this, but okay. Thank you. And also, there's a whole host of occupational, pediatric, therapeutic resources that are available in our community. And then this whole notion of developmental surveillance. So for families that are involved in the Child Protective Services system, there's going to, part of our planning and care with the family is developing a really robust network of support. And that network can involve a whole host of people. For substance-exposed infants, it can involve health practitioners, nurse practitioners, and representatives from different community agencies who serve this population. We're fortunate in our department to have 2 nurse practitioners who they're employees of our health department, but they're housed in our department and they serve only our clients. So we can bring them in post-discharge and assign them to go out and spend some time with the family and just evaluate how the infant is doing, continue to do the connection and education and providing resource information to the parents. They've got their eyes and ears on the baby and how the baby's doing, and communicating with the caseworker if there are any concerns, also communicating the progress that's happening. And if we're missing something, if the family's really struggling, what else do we need to put in place to ensure that everything's going well for the family? So part of the planning process is really talking about the developmental surveillance. Who is the baby connected to? Who is monitoring the baby's development and the care that they're receiving, and that sort of thing. So this slide really just goes over some of the community-based resources that we're typically going to use when we're serving this population. In human services, we have a whole array of what we call core services that's providing treatment and support to families involved in our system. And it can be mental health, substance abuse treatment, it can be in-home parent education, in-home support. We have some financial programs that help mitigate any financial barriers that the family may be struggling with. We have nurse family practitioner program. They prefer to get involved when the mother is pregnant. But that's an evidence-based program that we're seeing great success with in our community. We have a visiting home nurse who serves Medicaid patients, and they'll visit 1 to 2 times for postpartum families, do weight checks, education, connect to resources. We have Healthy Harbors that serves Child Protective Service clients. It's a medical home-based model, and they also serve Medicaid patients and clients who have a history of homelessness or are currently homeless. And then HCP serving infants birth to age 21, and these are for infants or children who have special needs or developmental concerns. And again, they assist with connecting the family to necessary resources. And then we have early intervention, and that serves infants birth to age 3. So in closing, what I can tell you is this is a work in progress. You know, we've been working at this since 2006. And then we had the rollout of Safe Care plans, which has helped us to complement what we've already been doing and to get a little bit more streamlined and efficient in our practice. But we're still in these, you know, the baby stages of doing it. Lots of work to do. What I would say to you, what's going well is our screening of moms, so that we have early identification. Reporting to Child Protective Services is going really well. I think our education that we're doing with providers and parents is going incredibly well. We have built in a problem-solving process, so if the hospital refers a baby and we get involved and things are breaking down, they're not working like they're supposed to, we can set up a special debrief and talk through what's happening with that circumstance. There's been an attempt in our community to educate Medicaid providers on the Eat, Sleep, and Console model. And then I would say just our efforts around collaboration. We know that the solutions to mitigate abuse or to prevent child abuse and neglect don't lie with one agency. It takes a collective responsibility of everybody in a community. And it truly has been a privilege to work with our hospitals around this endeavor. So some of the challenges, I would just say, you know, communication across systems can be a challenge at times. Documentation, it really needs to be streamlined in a different sort of way. In preparing for this presentation, I was pulling up some frameworks. The frameworks are where we document our family meetings. And I was looking for the goal setting and the action planning that's happening in the framework, and I can see the elements of safe care and all of that built into the plan, but then I think, the hospital doesn't have a copy of this framework, and I think the hospital's trying to document what they're doing, but we don't oftentimes see that in our record. So I think that there's a need to be able to figure that out. I don't think our way of tracking if safe care is happening is working out as smoothly as it needs to. We have this trails system. It's kind of like your EPIC system in the medical field, and it's very complex. It's always being built up and changed, and but one solution that was suggested, I think, was in the framework for the family meetings, is to have a little drop down and mark it as a safe care plan. So we have some way of tracking our efforts around this effort.